I'm going to start with a story, and I'm starting with a story because I hope that you will remember the story more than the details of what I'm going to talk about. So about 6 months ago, an 18-year-old that we care for at Seattle Children's Hospital, who was in college at the time, he's a Husky, so University of Washington college student, fell in the shower. While doing a transfer, he had an aide with him, and they fell together. And he had immediate right knee pain, and his left knee also was bothering him as well. And immediately he recognized that this might be a fracture, so called his parents who met him there, and he was escorted to our hospital, which is really just about a mile, literally down the road. When he came to our emergency department, he was immediately evaluated by the emergency department team, and I joined them shortly afterwards. And on exam, he was short of breath. And when I walked in, he had a nasal cannula, so that's a tube just in his nose. And I looked over, and I could see he was on like 5 liters of oxygen, in a kid who's not normally on any oxygen. And his parents shared that when the paramedics came and got him, his saturations were 77%. He also had a fast respiratory rate, so he was breathing hard. He had a fast heart rate. He had swelling above both knees, right more than left. And the other thing was he was confused. Now this is a kid who's very bright, smarter than I am, and confusion is not part of who he is. So some respiratory issues in the setting of falling and having some swelling in his legs, and he was confused. So those are the key points that I want you to remember as I talk about something called fat embolism syndrome. It is rare. It's exceedingly rare, but it's serious, which is why we wanted to talk about it today. It's an event following a fracture to the long bone, generally the leg bone, the femur bone, it may be the upper arm bone. It occurs up to about 7.5% of the general population. We're really not sure in the population of boys and men with Duchenne dystrophy. And the mortality in the general population is now quoted to be less than 10%. And what happens in the setting of a fracture or significant trauma is that fat, which is normally in the bone marrow of a bone, is released from the bone marrow, and it travels into the blood vessels as small little pieces of fat, so little fat globules, and that's called an emboli. And there's another theory that just the trauma itself and the normal fat that's in your system may actually cause an inflammatory response, and that too leading to the same fat emboli syndrome. It's described typically as occurring between 24 and 72 hours after a trauma, a fracture or trauma. The reality is it can occur immediately, and when I have seen it and read about it, it generally occurs immediately or within hours of a trauma. So what we know about fat embolism syndrome in boys and young men with Duchenne, again, it's exceedingly rare, and again, not clear how often it happens. But it may happen more than in the general population. And the potential reasons for that is that there may be increased fat in the bone marrow of a young person with Duchenne dystrophy. Risk factors include obesity. Steroids lead to increased fat in the bone marrow. And then bone that is osteoporotic, so low bone mass, also has an increased amount of fat in them. The other issue, as you heard from both our cardiologists and pulmonologists, is there are heart and lung problems that are associated with Duchenne, right? And so having baseline heart and lung problems may predispose you to having more problems with fat embolism syndrome. So what are the key features? It's respiratory distress, it's neurologic changes, and it's a funny skin rash called petechiae. So the respiratory issues that we think about, I described earlier in the young man: increased respiratory rate, decreased oxygen saturation, and then an increased work of breathing. So just working harder to breathe. Those are the classic respiratory changes we see. The neurologic changes, it can be a few. So confusion, which is what we saw on the exam in our young man, but they may complain of a headache. They might have a decreased level of alertness or interactiveness, and they may present with seizures, again, exceedingly rare. And this is a petechial rash. So It generally is not the first thing you see, so you may see this several days into a hospital stay after someone's been diagnosed with fat embolism syndrome. It's red or purplish rash that doesn't blanch, and blanching is when you put your finger on the skin of a rash, and when you pick up your finger, it turns white and then it goes back to the red. That's kind of blanching. And in a particular rash, it doesn't blanch at all. It stays red throughout the entire time you're pushing on it and taking your finger off. It's usually around the chest or the neck or under the armpits. So there's actually diagnostic criteria that are used in the general population to diagnose fat embolism syndrome. There's what's considered major criteria and minor criteria, and you can see them up on the screen. On the left side are the major, so the low oxygen saturation, the confusion, and that particular rash. You just need one major and 4 minor, which are on the right, or 2 major. And in the case of the young man I cared for, he had 2 major right away. He was hypoxic and confused. And then he had a lot of the minor criteria as well. So how do you diagnose fat embolism syndrome? It's really the clinical criteria, so using the criteria that was on the previous slide. But your providers in the emergency department or in the hospital may order other studies. So an arterial blood gas is basically just getting blood from your artery, and there's some normal levels that you would expect to see, and if those levels aren't normal, then that might point you in that direction. A complete blood count is looking at your platelet count, which might be lower, or an anemia from a red blood cell count. Blood and urine, looking for infection, or actually fat globules, which under a microscope you can see in both blood and urine. The chest x-ray may be helpful or not, but a chest CT, which is a much more sophisticated way to look at the lung structures, may show something called a ground glass appearance, and that's just a finding that radiologists or pulmonologists read when they look at that. You might have a CT or MRI ordered, especially if there's confusion, an EKG, and an eye exam, because the fat globules that circulate through the system into the lungs, into the heart, up to the brain, can also go not only to the skin, but can go to your eyeballs themselves. And so there's some classic features on an eye exam. So when a child comes in or an adult comes in with some particular symptoms that we're a little worried about, that this could be fat embolism syndrome, there are some other things that we think about. And frankly, we think about the other things first, right? Common things occur commonly, and so you want to make sure this isn't a pneumonia. In the setting of someone who fell, who might have some chest pain, you want to make sure they didn't fracture a rib or have a lung contusion, or head trauma if they're confused. Maybe they bonked their head and they had a concussion or head trauma, or an infection such as encephalitis or meningitis. So those are the things that people are going to think about, but again, we want to go back to fat embolism syndrome. So the treatment is early identification, recognizing the signs and symptoms of it. So if you are at home and you fall, if you have Duchenne, or your son falls, or your grandson falls, or your brother or sister falls, and they complain of pain in their leg, and then they are having some respiratory issues, so that fast respiratory rate or shortness of breath, you want to think about fat embolism syndrome, seeking emergency medical attention. And then here's the key. Here's the key. You need to alert the emergency medical professionals that you are concerned about fat embolism syndrome. The reality is that in our emergency departments, whether it's an adult hospital or a pediatric hospital, because this is so incredibly rare, people aren't going to think about it. They're going to think about pneumonia, right? So they have a kid in a wheelchair who might be in BiPAP at night. They're going to think about a pneumonia. Or they're going to think about something else and not think about this entity. The treatment is then to stabilize the fracture. So we don't want that bone to be moving around a lot, because that could send more fat into the circulatory system, which would then go through the system to the brain, to the lungs, and so forth. So splinting that fracture is going to be really important. Even before you know it's a fracture, a splint should be applied. Not a cast, but a splint. And then supportive care. So good respiratory care, cardiac care. If they need fluid resuscitation because their blood pressure is low, they might need a transfusion because their hematocrit or their blood count is low. And then stress doses of steroids may be indicated in this condition. Respiratory care is really key. I'm going to say something, I want people to remember it because I know this is contrary to what a lot of people hear, and maybe even here at this conference. Oxygen is good, right? Oxygen is not always bad. In the setting of fat embolism syndrome, oxygen is critical because they have a decreased oxygen saturation. Oxygen alone may not be enough. It's oxygen probably plus some mechanical ventilation, maybe non-invasive, like the BiPAP machine your son might wear normally at night to sleep. Or it may progress to the point where a breathing tube and mechanical ventilation through a ventilator is actually necessary. So how do we prevent this? Right? So this is something we want to avoid. So how do we prevent it? It's seatbelts, 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 seatbelts. Okay? That is the way we prevent this. We prevent falls from people wearing seatbelts. We prevent falls from learning safe transfers. So work with your therapy team at learning how to do a safe transfer. And we worry about falls mostly at the time of transitions, right? So when kids are just getting off their feet, and as a parent of that child, you're just learning to figure out how to do that transfer. So learn it ahead of time. Work with your therapy team because safe transfers are key. And safe equipment is key. So in the setting of the young man that I cared for, the bath chair armrest wasn't completely engaged. So it wasn't broken, but the caregiver didn't know to completely engage it. So literally, he was safely transferred and then went right out the other side because the armrest wasn't in place. So to summarize, fat embolism syndrome, it's rare, it's exceedingly rare, but it's serious. It occurs after a fracture to a long bone, again, mostly the leg, but it could be also related to just significant trauma. It's that triad of respiratory distress, confusion, and that classic petechial rash. Early identification is critical. And you, as the person with Duchenne, or the parent or caregiver of someone with Duchenne, has to sometimes be the one to point the providers in that right direction. You need to carry the alert card through PPMD that talks about fat embolism syndrome and hand it to those caregivers. Don't be afraid of insulting anyone or making us feel bad. We want to know. We want to know. And finally, the treatment is supportive. So oxygen is good, non-invasive ventilation, and then supportive care with whatever else is needed. Thank you.